Okay, while we're getting set up, we have one last trivia question left. And this is a pretty medium to easy one. So what is the clinical term or the fancy word for moving slow? You know, when your doctor... Bradykinesia, all right.
And what do you do for bradykinesia?
That's a question.
That's a question. Wait a minute. Don't steal my thunder. So, okay, we're going to get started. First of all, let's just give a warm applause for our excellent speakers today. Okay, I have a handful of questions, and then get ready. Do I have a runner for the mics? Yeah, okay. We have a couple. Okay, perfect. Okay, all right, here we go. So one question that was turned in is, and I think we'll direct this to Dr. Z, is what are your thoughts about CBD oil for a sleep aid?
Oh man, this question comes up so often about CBD, primarily because it's legalized now. So, I mean, listen, we all have our lives to live, right? Some people do CBD to help them sleep, to help manage anxiety. I would say if you're going to do it with the lowest dose possible. I will caution you and say that there's newer research that suggests that long-term use of CBD can impact your cognition, just like the other meds I was talking about. So, I don't know. I don't want to be too dogmatic and say no CBD at all, but if you're going to do it, be really careful, and I'd probably avoid it if you can.
Okay, great. All right. Another question is, I have challenges with bloating on a daily basis, multiple times a day, that lasts 30 minutes to hours. I have tried different solutions, including Gas-X and diet and fiber. Any other suggestions to help with bloating?
Yeah, I think that's very common. First step I think is to make sure that you don't have constipation, because if you're not moving things correctly, everything will get backed up and you can feel very bloated. And then the other part is, like we talked about, slow emptying of your stomach and changes in the microbiome and bacteria in the small intestines that can all contribute to bloating. So if you're moving your bowels and you tried diet modifications, then there are further tests to do about small intestinal bacterial overgrowth and some of these other things we see, which would require like a course of antibiotics to get rid of or hopefully improve. There's a lot more things to do other than diet changes.
Would you recommend an appointment with in your specialty area for that? If it doesn't go away, it sounds like it's a...
Yeah, I think if you've tried things, you're moving your bowels, and bloating is not better, then you should be treated for these things or pharmacotherapies to help with constipation or gastroparesis or small bowel intestinal bacterial overgrowth.
Okay, great. Another question that was turned in, Zoloft for anxiety or depression, what do you think?
That's a really broad question. That's actually one of the medications I listed that's been studied in Parkinson's. So the other name for it, the generic name, is sertraline, and it can be really effective for treating depression and anxiety in Parkinson's.
Okay, this is a topic that we didn't cover, but I'll go ahead and the question. Creatine has been used to increase muscle hypertrophy, but recent studies seem to also suggest that it may have cognitive benefits. Can anyone in the panel speak about this? Now, there was a study, over 10 years ago on creatine for motor symptoms, and one of the centers were here, and it didn't show any better benefit than the placebo-controlled group. But as far as cognition, anybody want to speak on any studies on that, or?
Well, I know that when they had people take creatine, I'm wondering if, because there's one, does the creatine help with the motor symptoms, or does the exercise you're doing while you're taking creatine improve your sleep? I don't know, I'm wondering, or cognition, because we do know that movement and exercise can improve cognition. So I don't know, I don't know the study, but it's possible that the effect of the exercise they were doing might have also had the benefits.
Okay. All right, it is your turn. Anybody have a burning question? Yes.
It's for Dr. Young. Dr. Young, I recently had a barium swallow test, and I got conflicting advice on the chin tuck for swallow. My primary care said try the chin tuck. The PT said there's new evidence that supported not using the chin tuck for the swallow.
Yeah, I think we have a speech language pathologist here that might give you a better answer than me.
Okay. This is Terry Kennedy. She is a speech therapist. Go ahead.
Aloha. So the question is, was the chin tuck meant, did they say to do it to prevent it from going in your airway? So that needs to be tested on the study you did. Most of the time we think a chin tuck protects our airway. It does not always. It shortens our pharynx, so it actually helps more with getting food from point A to point B better. But as for does this protect, it needs to be tested on that instrumental. Let me ask you this. When it went the wrong way, did you cough? You did cough, okay. So have you noticed not doing the chin tuck and eating? Are you coughing? Doesn't make any difference. Okay. Without doing it on the test, we can't be 100% sure. But if you had a cough reflex, that cough is going to tell your brain, hey, it went down the wrong way. At that point at the meal, I would say go ahead and try that chin tuck. But it doesn't always prevent. It's kind of humbug to have to do it if it's not working. So when did you get your test? Last week. Okay. Yeah. Well, they didn't do it. But check with me after. Maybe we can chat a little more.
Okay, another question? Chris. Chris, we're going to give you a microphone. Yeah.
How much REM at night? How much uninterrupted? How much sleep total?
Okay, I think the question was kind of asked. So the question is, how much REM and how much deep sleep should you be getting?
Uninterrupted.
Uninterrupted. Maybe, Dr. Z, you want to repeat the question?
Yeah, the question was how much REM should you get, how much deep sleep, and how much uninterrupted sleep?
That's what I got. Yeah.
And I briefly touched on it during the talk, but that's a tough question to answer. I mean, I think the easy answer would be totally uninterrupted sleep, right? But realistically, is that totally achievable? Probably not for many folks. So trying to minimize the amount of times that you wake up in the course of the night. And then in terms of REM versus deep sleep, we don't have control over that. Really, I think it's the best thing that you can do is try to focus on the interruptions that you do have, so you are able to consolidate your sleep and get more of that deep sleep early on in the course of the night. How much is too much? Yeah, I think it's really a balance. Again, not something that you can actively kind of change yourself. I know a lot of people I have an Oura Ring, other people have Fitbits and things like that. Not things that you can actively change. It's really, I think, just trying to improve the amount of interruptions in your sleep is going to be the best for you in the long run.
Okay, we have a question over here.
Hi. I think this question is for Dr. Farley. Okay, I'm older, and I was wondering, I exercise a lot every day, and I noticed that as I'm getting older, if I lay off for a day or two, like when I go on a trip to Japan, I come back and I feel like my muscles have all disappeared. So what is it that causes older people to not be able to retain that the strength that we have?
Dr. Farley, I'm going to repeat the question for the video and then before you answer. So, question was, we age, and if you have periods of time where you can't exercise because of travel or other reasons, how long does it take to lose your fitness level, and or why does it happen so rapidly?
I'm not imagining it, right?
No. Well, I'm old too, so I can answer that question. It's as the disease progresses, probably the importance of exercise and a regular program becomes even more and more important, because your medications and your exercise are really kind of working synergistically. Probably your activity is by itself improving your symptoms, but also maybe helping your meds work better and more efficiently, that kind of thing. So I'm not surprised that after a few days you feel weak. That doesn't mean you're actually weaker. It just means sort of cognitively, or the effort, you feel like you have to work harder maybe to move, and it's fatiguing. And those kind of symptoms are common in people. Sometimes people overdo it, and that also you don't want to do because that's stressful on the body. But also if you're gone a few days or a week, I will say if you told me that, I would be, whatever you're doing is probably great because you're exercising and it's making you feel better, and you notice when you quit that you don't feel so good. So that's a sign that you're actually probably benefiting. And maybe your medications, if you were going to go a whole week without moving, that might be something to talk to your doctor about, because you don't want to be, you want to be able to go on vacation and do some things even when you maybe can't exercise. So does that help?
We have a question over here. Yeah.
So for people who already do a sport, paddling, it can be anything, yoga, running, hiking, is there any outreach, so resources for coaches to help them to be able to carry on what they are doing with maybe some modifications?
That is a wonderful question. Glenn and I were just talking about it the other day. So one, your coach can be even a physical therapist. I would highly say go there, at least start there. And then if you find other sports related people or fitness who you work with anyway, because you're doing paddling or kayaking or whatever, you can approach them. But I don't know, there's not coaches, there's not a training program yet for Parkinson's coaching. I think that's something I might do when I retire. That might be something that would be really good. But that therapist could help you. They could sort of have you practice things, sort of like a scenario of what might help you with a paddle stroke or getting in and out of something that's related to your sport. We actually go play pickleball and tennis with people and do stuff outdoors just for that reason. If that's what they like to do, we want you to keep doing it. So I don't know if that helps, but I would start, and then you might just talk to a coach, and they may want to. Maybe they can, for one, I'm sure they can help some, but your therapist could talk to them too and help them understand some of the ways to make it modified or adapted.
Great. Any questions over this side? Over there?
I have a question regarding CPAP, and if you have any experience with the implantable, I think it's Inspire, or the ones that require the surgical implants.
You've probably seen all the commercials lately. I think you were talking about the Inspire device. Hasn't been studied in Parkinson's. And for everybody in the audience, for some people with sleep apnea, what happens is that your tongue falls back when you're asleep, and then that leads to the snoring, and it can lead to basically stop breathing. The Inspire device stimulates the nerve that controls your tongue, and so when you breathe in, it moves the tongue forward. My understanding of this, and I don't practice sleep medicine fully anymore, but my understanding of it is it's really only for people with mild to moderate sleep apnea. But really, we all sort of feel like CPAP is still the gold standard for treatment. There's also like other considerations that the sleep surgeon will have to make in order to, qualify you as a candidate for that device. So it's not an easy question to answer.
All right. Okay, question over here. Mike's coming to you.
Any recommendations on daytime drowsiness?
Yeah. So improving your sleep at night can be really helpful. And when I say that, I mean improving the amount that you sleep at nighttime. But people with Parkinson's can still have daytime sleepiness. And some of the things that can be helpful are caffeine. So if you're not already drinking a cup of coffee or tea in the morning, I would certainly do 1 or 2 cups, because that's been shown to be helpful for increasing your alertness levels and that sort of thing. Medications that you take for Parkinson's also can impact your sleepiness, and specifically can cause sleepiness in some cases. So talking with your doctor about adjusting that, if there's a specific time of day when you're feeling more tired, maybe reducing the amount of levodopa that you take can help. Then you sort of get into other things that I'm not super thrilled about, like stimulants. That have been studied for daytime sleepiness, and really, I only reserve that for very extreme cases of people who are falling asleep. But at the end of the day, if you're taking like a 1-hour nap during the course of the day, that's okay, as long as it's not significantly impacting your quality of life. Then
One
just
more
run with it.
question on melatonin. What is your dosage recommendation?
Depends on what it's for. So there was a question earlier. I talked to somebody about REM behavior disorder. There you are. Hey. For REM behavior disorder, which is a sleep disorder where people act out their dreams at night, can happen before or after you're diagnosed with Parkinson's. I often start with 5 milligrams, and you can go up to a maximum of 15. But for people who are just having trouble sleeping, I'll often start with somewhere between 1 to 3 milligrams. And you can kind of work your way up and down from there. There have been other studies in Parkinson's that have looked at that, even up to really high doses, but I prefer to stay on the lower end because your body still produces it. You don't want to suppress that natural production.
Thank you.
Yeah.
I have a question.
Oh, okay.
It's regarding bradykinesia. Is the activity you do, does that affect the degree of bradykinesia you experience? So in other words, if you do more high intense workout, will it help with easing the symptoms of bradykinesia?
So even in my first clinical trial where we only did whole body, big and fast movements that involved the eyes, hands, breath, voice, everything, people got better, meaning they walked bigger and faster, their transfer times were faster. So in terms of behavior, you can the training can have an impact on those movements in your daily life. And I think that was your question. Also, I will say that levodopa, the number one thing it improves the most is bradykinesia. So sometimes when I see people really struggling and they just cannot, they don't have the vigor and they can't really get their full mobility and their whole body activated just with their attention and cognition, I recommend they talk to the doctor because they're trying so hard and they can't, and sometimes it just takes a little bit extra levodopa to get to that optimal sort of place.
Thank you. I have one other question, if that's okay.
Okay, yeah, you got the mic. Go.
It's regarding stem cell, although nobody here is necessarily, and I shouldn't say that, but stem cell, is there any update or any general information on the use of stem cell therapies?
I'm going to kick this to Dr. Z. He's a neurologist on the panel, so.
This is kind of like the CBD question. It always pops up, at support groups like this. Stem cells largely have been a failure in clinical trials. So at this point, I would say don't spend, big money on this because it's not FDA approved, number one. Number two, if you're going to fly somewhere else to get this done, and pay money for it, you want to be sure that it's going to help. And at this point, it's just not been shown to be helpful. Now, that being said, there's a big clinical trial being done. It's in a phase 2 trial, which means that they're using this in people with Parkinson's in a larger group to see if it's efficacious and safe for people with Parkinson's. It's run by a group called Aspen Neuroscience. So it'd be worthwhile to visit their website and read about what they're doing. And this is talking about injecting stem cells into the brain of somebody with Parkinson's as a way of helping to regenerate dopamine-producing nerve cells. So TBD on that, but as of right now, don't spend money on it. Yeah.
Okay, we right back here, and then behind her after that.
How about low T or testosterone for men, for weight during the day, drowsiness?
You're asking about testosterone?
Yeah, the hormone for
The hormone for testosterone for motor symptoms?
low energy.
For low energy. So the question is testosterone been looked at to help with low energy?
The honest answer is I don't know. Testosterone treatments are really popular among older men, and there can be a lot of side effects that come with it. So I don't know. I certainly wouldn't, again, spend money on this for just low energy. I think there are a lot of things that people can do with either their sleep or focusing on their Parkinson's to help with low energy before I'd focus on, low testosterone.
Okay, we have a question over here. Yeah.
I have a question for REM sleep disorder, or used a slightly different term, but acting out your dreams in your sleep. Trazodone, would that still be effective?
Can you speak into the mic a little more?
Sorry. Question for REM sleep disorder, or acting out your dreams in your sleep. Would trazodone still be an effective drug to help with that cause of poor sleep or reduced sleep? And if so, when you mentioned it earlier, low dose, I was wondering what the low dose actually was.
Dr. Z, let me repeat the question for the video so people can. So the question was for acting out your sleep and hypermovement at sleep. Is trazodone an option, and what is the dosage? Is that close?
Yeah, so REM sleep behavior disorder, again, is a disorder where you act out your dreams at night, and can happen before you're diagnosed with Parkinson's or be a symptom after you're diagnosed. Trazodone is not a treatment for it, primarily because it can actually worsen it in some people. But for somebody who's dealing with insomnia, you're not sure why that's happening, and you're just trying medications, we often use low doses of trazodone at 25 milligrams or 50.
Okay, we have a question in the back. Go ahead.
Yes. I wanted to know if obsessive compulsive behavior is a symptom or can be a symptom of PD, or is it primarily from the medications that you're taking?
So the question is obsessive compulsive behavior. Is it an actual PD symptom or a side effect of medication? So I'm going to Dr. Z, the neurologist of the panel.
Obsessive compulsive behaviors, I guess that there's maybe two ways to think about this. One is sort of like, repetitive behaviors, like touching doorknobs, touching utensils, repetitive movements that you do. And I'm not entirely sure that that's associated with Parkinson's. There's something called impulsive control behaviors or disorders that can happen as a result of Parkinson's. That's something I mentioned in my talk about, gambling sort of impulsively, snacking, other behaviors that sort of are reward seeking, that can happen as part of Parkinson's or because of the medications that come with it. A lot of people, if you're asking about obsessive compulsive behaviors, a lot of people can have that in the context of mood disorders like depression or anxiety. So treating those things can help you with the obsessive compulsive behaviors that you might be experiencing, if that's what you're asking about.
Okay, I've got a question regarding melatonin. Oh, melatonin. So over the counter, you have the 5 milligrams, the 8, the 12 milligrams. Is it detrimental if you take the 12 milligram for a prolonged period of time? Would it have a negative impact on your body, your brain cells, etc.?
The answer is we don't know. Melatonin hasn't been around that long, and it is not FDA approved. It's a supplement, so you can just get it over the counter. I think at the end of the day, when we use doses of melatonin that high, we're using it for people who are really acting out their dreams and at risk of injuring themselves during the course of the night. So it's sort of this balance, right, of should I worry about the risk of taking a high dose of melatonin for the long term, or do I worry about my physical safety overnight? And you can keep taking the melatonin 12 milligrams, pretty much forever, if you're on it for REM behavior disorder, again, for your physical safety.
Okay, I have a question for Dr. Farley. Could you talk about the importance of intensity during exercise to tap into the benefits they saw, like in the forced exercise study, Dr. Albert and all those?
Yeah, so people get really, like when they hear what they did in the studies, 70 to 80% heart rate for 30 plus minutes, holding that average heart rate, people freak out, and I don't blame you. It's kind of like, oh my God, how am I supposed to do that? Most people that are healthy cannot do that. And it takes 1 to 3 months to develop a baseline conditioning to be able to do that. And it may even be longer in people that are sedentary and older. So one, don't panic. It's really about starting where you're at and training both motor and cognitive engagement and effort, just till you get so that you start moving with more vigor, you start being engaged more with your attention and working harder overall. And then starting to integrate more repetitive exercise of strength or bike or treadmill, where you can do 10-minute bouts. There's research that a 10-minute bout twice a day, 2 times a day, or like 3 times total, is just as helpful as a 30-minute bout. So you don't have to just achieve like what is in the research. So I don't even like to talk about it sometimes. If you're a habitual exerciser, yes, if you want to look at your heart rate, sometimes heart rate doesn't even reveal how hard you're really working. It's about your sense of effort. Are you out of breath, you can't talk, or you're sweating, then you're in that highest zone where you want to try and maintain it more often. So I hope that helps. You want to work hard physically, but also cognitively. You want to raise the bar so that sometime during the day you're just challenging yourself. And don't worry about the minutes. Over time, the more you do it, that you can increase the durations and the intensity.
Great. I know in the exercise classes that they have here at the Wise, we teach them to incorporate HIIT training, high intensity interval training, where you have these short little bursts of energy or movement throughout the cycle. So
yes, and there's research on that in Parkinson's, and it's just as useful as trying to hold something continuously. In the studies on aerobics, they told people your goal is to get to this 75%, let's say. But people would get there, and then they'd have to take a little break, and then go back. And so over time, that gets easier. And interval training is, yes, very effective, where you do like 45 seconds on and then 20 seconds of rest or another activity. So, yeah, definitely that is better for people that are deconditioned too. They've shown it's easier to train and improve your ability to hold those effort levels if you maybe start with high intensity intervals.
Great. Over here? Yes.
These days, there's a lot of advertisements on TV about this little pedal thing that you can put, and you can pedal and under your desk and watch TV, and no one knows you're using it. Is that adequate?
Okay, let me repeat the question again for the video. So the question was, on TV, they call little foot restorators, or basically pedals. that underneath your desk, is that beneficial?
Well, it is good for circulation. It's good for some mobility if you have arthritis and you want to move your hips and knees and ankles. Does it, but I'm not, if your heart rate isn't going up, I wouldn't count it as necessarily an exercise. It's more of an activity, and which is okay, it can add up, but it's not really going to replace, I guess what I would say, your exercise session. But again, it depends on you. If that's all you can do, I would start there, and then I would start adding some other activities to go with it, where you're doing more chair exercise and movement and upper body stuff. So not like you can't do it, but it's not necessarily going to count if you don't add to it.
Okay, we have over here, a question over here.
Okay, this question is for Dr. Z. I wanted to know if the new treatments for the motor symptoms that you had talked about earlier, how do you need approval to get onto the pump for the levodopa pump?
I should give this question to Leilani, who works with AbbVie, the company that brought this medication to the market. So you're asking about Vyalev, which is a pump that administers levodopa under the skin all throughout the day. And the answer is that yes, you do need to get approval for it because it's only recently FDA approved. You have to demonstrate to your insurance company that you've tried a number of different medications to treat the ups and downs of motor symptoms with Parkinson's in order to get on this. And even still, if you get approved, there may be a cost to you as the patient. I think the only exception is that if you're under 62 and have private insurance, and I forget which private insurances that is, the company will take care of the cost for 2 years, but that also has to be applied for, and you have to meet certain criteria for that.
Okay, will gastroparesis be one of the items that will qualify you for the pump?
I don't think so. Yeah. For Vyalev. Yeah. I mean, gastroparesis or difficulty with bowel movements can influence the way that medication is absorbed in your body. But the insurance companies really are looking at the types of medications that you've tried and if the ups and downs of your motor symptoms related to Parkinson's are affecting your quality of life.
Okay, because I deal with a lot of freezing spells because the medication doesn't stay in my system long enough. So I tend to fall on my knees a lot, or I lose my balance.
Those are really hard symptoms to deal with, especially when your medications aren't working well for you. Maybe we can talk offline about that, but I would recommend you talk with your neurologist about what are the options available to you. Yeah.
Any other questions? Tommy has one up front.
Therapist to work with, somebody that's really good at outlining a couple of different programs that they feel are effective in training yourself to be more astute with choosing a good therapist to work with.
What type of therapist?
A therapist that would teach you the
Like physical therapy, speech therapy, physician?
Yeah, all of the above. But
Okay. I'll answer that one. So the Hawaii Parkinson Association, our website is parkinsonshawaii.org. We do try to keep up on the local resources for all those areas. So we have a listing of all the movement disorder neurologists, which are the Parkinson specialists. I always talk about like if you need to see a specialist, let's say I hurt my hand, I'm going to go to a hand specialist, not a knee guy, right? So kind of same thing with the specialist for Parkinson's. Not every neurologist, physical therapist, speech therapist is trained in Parkinson's. So we're aware of that. So if you get on our website, we have a listing of the people that either have certifications or for Parkinson's. So that's one resource. So I would direct you to the website. Aha. And also, if you visit Pat at a resource center, there's this nice handout of all the community resources here on the islands. And it's probably online too. If you get on, it sounds like an infomercial, parkinsonshawaii.org. So we do have those local resources for you. Question in the back?
I have a DBS for about 3 years, and I was wondering if there's a noticeable change in the amount of electrical charge that you use, because I started out at about 120 and it went up to 140, 145 on my left and right side. And then I have 2 electrodes. And then lately I've had to decrease it.
Okay, so I'm going to repeat the question. So the question is, with deep brain stimulation, is there a maximal limit to how high the settings can be? And are there reasons that you would want to increase it or decrease it? And if you have to increase it, is there a limitation to that? Is that accurate, what you're asking?
I increased it and I started having more tension and cramping in my legs. So I decreased it. At night, it goes down to 110 on both sides. And during the day, I have it at 120.
Okay, and you're manually turning it down?
Yes.
Okay. Do you want to handle that, Dr. Z?
Yeah, so deep brain stimulation could be a really effective treatment for people who have ups and downs of their motor symptoms related to Parkinson's disease. And there are a few other criteria that you have to meet to get that therapy. The effectiveness of DBS depends on a few different things. It depends on where the electrode is implanted in the brain, how accurate the surgeon is, and it depends on the skill level of the neurologist who's programming your neurostimulator. Or you may have some help from some of the device companies and the representatives who come to the visits. These are really small structures in the brain. And as you increase the stimulation to try to help symptoms like tremor, stiffness, or slowness of movement, that stimulation can touch other parts of the brain that can create side effects, which is what I think you're talking about. And in those situations, you at home can reduce the amount of stimulation that you get to avoid those side effects, but your neurologist may try other settings on the stimulator to help you navigate or avoid those side effects, but get the best benefit from the DBS itself. Does that make sense? Okay.
Another question that came in. What are the possible causes of abdominal pain in Parkinson's?
Oh yeah, that is a pretty big question. So, the most common thing we see is constipation in the GI tract, and that can definitely cause pain. It just kind of depends where the pain is and any other associated symptoms. I would say constipation is the most common. If you have nausea, bloating, associated other symptoms like this, we do see the gastroparesis or small intestinal bacterial overgrowth. So it's a pretty general question, but in order to target it, it's important to see what else type of symptoms is associated with the pain itself.
I'll add to that just a little bit in that there definitely can be sources of abdominal pain that are non-GI related as well. So especially with some postural dysfunction in Parkinson's disease, we can see tight muscles or even sometimes nervous system causing some abdominal pain as well. If there's any spinal restrictions or limited mobility there, we want to take a look at that as a whole to make sure we're not getting referred pain from elsewhere.
Okay, we're running a little bit late, so one last question. We'll take one more. Does anybody have one more burning question? You may.
This is for Dr. Z. I think you're popular today because we had to all wake up early for this and we're ready for a nap. But what are your thoughts on tart cherry juice?
Well, could you repeat that? Because
Oh, you can't hear me?
Oh, now we can.
Oh, okay. What are your thoughts on tart cherry juice? Do you know about tart cherry juice? For sleep?
I mean, I've heard about tart cherry juice sort of in general, to help people anchor their sleep rhythm and kind of get to sleep a little bit faster. To be honest with you, I haven't really read on it just because it hasn't been studied in Parkinson's that much. But at the end of the day, like, it's a pretty innocuous intervention. And if people feel like tart cherry juice helps them to fall asleep, then there's not really a lot of harm in trying it out.
Yeah, I feel like people should try it. Like, I've tried melatonin, I've tried a bunch of, meds and whatever. But the tart cherry juice works for me. And it tastes good, and you can get it at Costco.
Okay. Okay, one last question, and then we're going to have to cut it off.
UTI. It was brought to my attention that people our age don't know we have UTI. Is that true? And what are the symptoms and whatnot?
I couldn't get that.
So just to repeat the question, she said it's been brought to her attention that sometimes people her age are not aware that they have a urinary tract infection. And that can be very common with aging, is the symptoms actually change. So instead of having the usual symptoms of bladder pain or urinary urgency and frequency, you might actually see more cognitive decline, confusion, other things like that, rather than that just pure bladder pain. But typically it still is associated with a more frequent urination or more incontinence. So you would want to watch for those symptoms as well. But if something is abnormal for you or you're feeling unwell in general, that's a good time to check in with your doctor or an urgent care just to have that urinalysis done. Quick, easy test.
All right. Guys, thank you very much. I'm going to turn over closing comments with Glenn first in just a minute, but thank you to our excellent speakers today again. We are so blessed to have them. Also, thank you to you guys. I mean, we maxed out, right? So we had a waiting list, and thank you for being engaged the whole day. I hope it was beneficial. I hope you have some golden nuggets of knowledge to take, and thank you for that. Thank you for all of our sponsors. I'm going to turn it over to Glenn for some closing comments.
Kevin, you stole my thunder. And my jokes, too. How about a big hand for Kevin Lockett? He did a great job as moderator. Yeah. As Kevin mentioned, I want to thank our speakers again, Dr. Becky Farley, Dr. Z, Dr. Craig Young, and Dr. Brianna DeWitt. Thank you to our sponsors, AbbVie, Acadia, Amneal, Bayada, Insight Tech, Medtronic, Michael J. Fox Foundation, Queens Medical Center, and St. Francis Healthcare System of Hawaii. Thank you for sponsoring this event. I want to say thank you to our volunteers who gave up a lot of their time and energy for the symposium. Thank you very much. Thank you to Hawaii Pacific University, Aloha Tower Marketplace, James, Derek, and Diego, who are our AV guys. They did a great job as well. And finally, want to thank all of you for coming out to our symposium today. And we here at Hawaii Parkinson Association are here to serve you. And we want to know how we're doing, so let us know what we can do more of or what we can do better. Okay, so please, mahalo for attending today. Please drive home safely, and aloha.